علامة من علامات الاندوكرينولوجي في مصر وهيقول لنا الدكتور سمير how different is papillary thyroid microcarcinoma from papillary thyroid carcinoma. اتفضل يا
شكرا جزيلا استاذ خالد. اولا كل عام وانتم بخير بمناسبه المولد النبوي الشريف. يعني انا دلوقتي هننقل على يعني كوتو دايابيتس. طبعا الدكتور تامر كلمنا فيري نايسلي على باراثايرويد، صحصحنا شويه. الباراثايرويد طبعا دايما اكسايتنج. احنا هننقل على موضوع تاني which is important for the not only for the endocrinologist, it's important for the general practitioner and the internist. And nowadays we are seeing a lot of thyroid cancer, and they do not need to be seen by a seen by internist, even followed by general practitioner. So that's why in the next 20 minutes I'm going to follow these steps. First, I'm going to talk about definition of papillary thyroid microcarcinoma, how to differentiate between it and the ordinary papillary thyroid carcinoma, the types of microcarcinoma, the prognosis, and in the end, I will be discussing how to treat these patients. First of all, I'll give you a background on thyroid carcinoma. Papillary thyroid carcinoma is the most common of the thyroid carcinoma. And thanks God, it's the most benign of them, or less malignant than the other one. And at the background, the name papillary carcinoma comes from the pathology. There are papillae. I will show you the picture, papillae, with a core inside. And this core of vascular tissue is covered by... And these cells are abnormal. They look in the microscope. If you look at the cytoplasm, they will have a clear cytoplasm. That's why they call it the ground glass appearance. And the cytoplasm will go inside the nuclei in the form of intranuclear grooves. So if you read in the pathology, these two terms, clear nuclear, intranuclear grooves, with papillae, this is papillary thyroid carcinoma. And this is the pathology of the net, the typical papillae with the fibrovascular tissue. So this is the papillary thyroid carcinoma. So what is papillary thyroid microcarcinoma, the PTMC? It's actually a variant or a form of papillary thyroid carcinoma. And if you go to the definition, is papillary thyroid carcinoma less or equal to 1 centimeter? This is the WHO since 1988. So 1988, the definition of the WHO was that papillary thyroid carcinoma foci less than 1 centimeter or equal, this is papillary thyroid carcinoma, the microcarcinoma. Dr. Alia, do you want me to stop? We can stop for a few minutes. Okay? We can stop. No, we can stop for a few minutes. We can stop for a few minutes. I would prefer that. But there's the chairman. Okay, stop, huh? معلش اسمحوا لي عذرا ان انا شخصيا وبالتالي كلكم لما اسمع كلمه الله سبحانه وتعالى ما اقدرش اقف او اتكلم. لازم كلنا نسكت ونحترم سبحان الله تعالى. فاعذروني اذا كنت وقفت المحاضره. وبالتالي كلكم موافقيني على كده، واحد يسمع كلمه الله المفروض. انا بشكركم على نرجع تاني لل WHO definition. Papillary thyroid microcarcinoma is less than 1 centimeter. So is it the end of my lecture? This is the only difference. Papillary thyroid carcinoma, less than 1 centimeter. This is papillary thyroid microcarcinoma. So this is the end of my lecture. But actually, Professor Tamer asked me to speak for about 20 minutes. So I have to go further to talk about certain difference between the papillary microcarcinoma and the ordinary cancer. I continue. I want to clear certain nomenclature. There is a nomenclature called micropapillary thyroid carcinoma. It's different from papillary thyroid microcarcinoma. Micropapillary, this is a pathologic terms in which the papillae, as you see, are not like ordinary. This is on the left side. This is focus of parathyroid carcinoma less than 1 centimeter. And this is another patient with micropapillary. This is thyroid carcinoma, and the papillae are smaller. They don't have a core, and the nuclei have got what we call the hobnail appearance. زي مسمار النعل يعني. So we have to differentiate between papillary thyroid carcinoma, which I'm talking about now, and the micropapillary, which is a bad prognosis. The micropapillary has got aggressive clinical course, more frequent external extension, and more frequent distal metastasis was lower term. So we have to speak about the difference. Now, from now on, in the next 10 minutes, I will be speaking about papillary thyroid microcarcinoma. Papillary thyroid أقل من سنتي. So what are the differences? The age is not different between the two cases. The gender is not different, and the multifocality, because usually multifocal. This occurs in papillary thyroid carcinoma. This is we have seen a lot of cases, not one foci, but multiple foci on one side, on either side. But the difference between them is that the microcarcinoma, the metastasis to the lymph nodes is less, the bilaterality is less, capsule invasion is less, the disease recurrence is less, with a higher rate of incidental findings. How did they get this reading from different studies? This one was 10 years ago. You can see that this patient was microcarcinoma, the bilaterality is less, the lymph node metastasis, capsule invasion, disease recurrence is less, but the incidental diagnosis, which I'm going to talk in 1 minute, inshallah, is more with micropapillary, and the autoimmune thyroid disease association is more with the micropapillary. Don't forget that patient with autoimmune thyroid disease, whether hyper like Graves or hypo like the famous Hashimoto thyroiditis, you can have an incidental finding of papillary thyroid carcinoma in these patients. So don't forget that. What about the incidence? It's growing, and it's explainable because we are doing a lot of ultrasound for anything. And also we are doing a fine needle aspiration almost every day. So they are common. About 40% of patients with papillary thyroid carcinoma as microcarcinoma. So this is important. And more important than up to 1/4 of benign thyroid disease, after surgery, they can have a focus of papillary microcarcinoma. 1/4 of patients operated by the surgeon for benign thyroid, they do have a small focus. That's why I guess talking about this topic is important. We have to talk about classification. Very important. We have got the papillary thyroid carcinoma is classified into three types: incidental and non-incidental, occult and latent. Let me start. This is papillary thyroid carcinoma in autopsy. مالناش دعوة بيه. Ocal papillary thyroid microcarcinoma is important. Patient presented with lymph node. Biopsy shows metastasis with thyroglobulin positive cells, means that it's coming from the thyroid, and they find a microcarcinoma. This is very uncommon. So microcarcinoma with evident lymph nodes. But the most common is the incidental finding. Incidental finding discovered, as I mentioned, after surgery for benign disease unexpectedly, or during doing an ultrasound. I remember the study we have done in our unit about the screening for ultrasound for all the students, and we discovered one of medical students with papillary thyroid carcinoma. But this is incidental. And don't forget, this was a research, because I'm talking that you shouldn't do routine ultrasound for, you are talking about diabetes and above the age of 35. This is not doable. You cannot screen all the patient by ultrasound. Even the USA now speaking, even not to screen them by palpation. Anyway, the papillary thyroid carcinoma ultrasonography is very rather pathognomonic. Microcarcinoma, irregular border, taller than wider, and very vascular on Doppler. And fine needle aspiration is very important. But remember, you are going to fine needle this patient with less than 1 centimeter. What do the guidelines tell us? The guidelines tell us that not to biopsy thyroid nodules less than 1 centimeter. Unless you have high suspicion by ultrasonography, microcalcification, irregular border, or history of irradiation. So remember the three. If you've got any of the three, please do biopsy these patients. Otherwise, don't put a needle in a nodule less than 1 centimeter. What about the prognosis? You can see that 10%, the risk of having growing 3 millimeter over 10 years is 10%. So it means that approximately 90% or more, they do not grow of this microcarcinoma. Second important thing, that the risk of having tumor spreading to lymph node is only 4% over 10 years. So this means that approximately 96% of the papillary thyroid microcarcinoma, they do not spread to the lymph nodes. So it seems they've got excellent survival, excellent prognosis. And the problem is that elderly patient, or patient, as I mentioned, with a history of irradiation to the neck is different. Papillary thyroid microcarcinoma can be a little bit of bad prognosis. Now let's go back to this. Is this benign? Is the PTM, because I mentioned survival is more than 97%, gross more than 90%. So is it really benign? The problem that we've got in this study by Danella 3 years ago, they discovered that in patient operated for any benign disease, that 1/4 of these patients, they did have microcarcinoma. And they discovered that 14%, above the other series, so it's reading above expected, 14% they did have extracardiac invasion. So that's why they said, no, we had to look again, saying that not all papillary microcarcinoma are benign. All of them. So they put what you call the prognostic score. They dependent on the age, so age above 65. If the size is above 5 millimeter, if there is multifocality, lymph node metastasis, distant metastasis, extrathyroid extension, you should, this patient can behave like ordinary papillary carcinoma. You should be more or less doing the classic treatment, as I'm going to speak in 1 minute, inshallah. What about molecular markers not found in Egypt? Is that they found that that molecular genetics, after doing biopsies, they can stain from the BRAF. If they are BRAF positive, they're more likely to behave badly. So this is one of the important score. A very important differentiation between incidental and non-incidental. Remember that I told you that incidental is the most common. But the non-incidental microcarcinoma, this means patient operated for some symptoms, for a nodule which you have palpated. Sometimes you can palpate even less than 1 centimeter because sometimes it's hard. So in these cases, it's not incidental. This is non-incidental. So you send them for surgery. And the non-incidental microcarcinoma, the behavior is worse. Actually, the recurrence rate is much higher. They are more aggressive, more lymph node metastasis. So remember, if it is not incidental, you have to follow the rules of aggressive treatment as I'm going to talk. The last point, in the last couple of minutes, I'm talking about how to treat these patients. Of course, if you hear thyroid carcinoma, surgery comes number one. Whatever you're going to do, total or needle thyroidectomy or lobectomy. And on the other hand, there is now the school of active surveillance or active surveillance. And this means that some patient with microcarcinoma, you do not need to do surgery. This is the extreme. Only follow-up. I'm going to show you the data. Of course, if you are going to do surgery, are you going to do neck dissection? Because if you do neck dissection, more and more complication. Are you going to give radioiodine treatment to all these patients after surgery? I'm going to discuss shortly. So as I mentioned, there are different therapeutic ranges coming from surgery to no surgery, followed by radioiodine or neck dissection for the lymph node, by a Japanese as well as a Korean group. Because now there was the last guidelines coming from Korea about how to deal with this microcarcinoma. Actually, it came from Korea. Because in Japan and Korea now they got a school. Some of these patients, I will show you the data. Some of these patients you can data. Of course, I don't think in Egypt we can follow these rules. Some experts in the USA say you can do lobectomy. But lobectomy, we've got a risk of having, because you remember, can be bilateral. So if you do lobectomy, this will be a risk. So now, what is the standard? Total or knee total thyroidectomy. This is the standard for papillary microcarcinoma. Neck dissection only if there is capsule invasion or cervical lymph node biopsy, preoperative by the ultrasound or biopsy or intraoperative. And post-operative radioiodine only in patient with distant metastasis or extrathyroidal invasion. Please remember the last phrase. Because we are seeing, unfortunately, patients sent for radioiodine for a lesion of 7 millimeters. Please remember, this is treatment for papillary thyroid microcarcinoma. And the surgery is better, as I told, because it is multifocal to do near total. If you do near total, you can follow this patient by doing what we call the iodine scan. You cannot follow this patient with iodine scan, radioiodine scan, after lobectomy, because most of the iodine will go to the other side. So if you want to follow this patient for any risk of recurrence in the lungs, bone, or brain, or whatever, you have to do total or knee total thyroidectomy. And again, by follow-up by thyroglobulin, you cannot do that if you remove the heart, because thyroglobulin will be detectable. And this is David Cooper, one of the eminent USA thyroidologists from the American Thyroid Association. In 2009, he got this, which is similar to what you are doing now clinically. If you got a patient with papillary thyroid microcarcinoma less than 1 centimeter, if it is unifocal, you are sure that unifocal, intrathyroid, with no lymph node metastasis or distant metastasis, you can do lobectomy. On the other hand, you do total thyroidectomy. And I said, probably we will do total thyroidectomy. If there is lymph node metastasis, whether preoperative or intraoperative, you have to do therapeutic intraoperative or prophylactic removal of the lymph node dissection. And if you remove the lymph node, if there are distant metastases or extrathyroid invasion, you do radioiodine. So you don't do radioiodine after near total, even after central neck dissection of lymph node. Only if there are distant metastases or gross extrathyroid. On the other hand, if after total steroidectomy, there are no lymph nodes and the tumor is very small, T1, or you have to follow up, no radioiodine. So radioiodine is given only for a small category of patient with papillary thyroid carcinoma. This is the indication of radioiodine. Patient elderly above the 45, distant metastasis, lymph node metastasis, capsular invasion, vascular invasion, encapsulated tumor, multifocality, non-incidental cancer. You should be more aggressive in this patient, and you can give them radioiodine. Otherwise, if you don't have this, don't give radioiodine, even if the oncology persists, insists. So don't follow his steps. And this is a very interesting publication last year in the New England Journal of Medicine, the most snubbed أكبر مجلة في العالم. The patient with low thyroid cancer, the giving radioiodine didn't do any benefit to this patient, as I told you, only in certain category. Last part of my talk, I know that you are tired. It's about surveillance. Surveillance, remember, you have diagnosed papillary thyroid microcarcinoma by biopsy, ultrasound, you are sure, and you say, no, I'm not going to send you to surgery. I'm going to follow up you for several years. What are the indications? According to the Korean guidelines, the last one, few years. If the type is not very highly malignant, if the tumor size is less than 5 millimeters, the tumor not near to the thyroid capsule, if there is no invasion of the surrounding tissue, if no lymph node, no family history, no neck irradiation, you can follow this patient. At the last phrase, patient having a little psychological pressure and can cooperate. And I think this last phrase doesn't apply to our patient in Egypt. If you tell me, I've got thyroid carcinoma, Dr. Samir, I'm going to follow you up every year, I won't be very comfy. Are you going to be very comfy? No, I wouldn't. So this depends on the region where you're going to apply. But in Korea and Japan, they are having very good data, and they are following this patient now for years. And they only send them to surgery if the tumor grows more than 3 millimeters or there are lymph node metastasis. So at the end, what about the most recent way, non-surgical? Heard, I guess in last time, Dr. Iman, about the thyroid ablation using the radio frequency, and some of the doing it in Egypt, not very few, but in Korea and Japan is being doing it very commonly now, as well as in Italy. And they did show that if you induce the needle with radio frequency or microwave, you can treat this papillary microcarcinoma. But this is not for us, not for Egypt, please. The last slide is about overdiagnosis. USA Preventive Task Force in 2017 said, we are overdiagnosed papillary thyroid carcinoma. We are over. Okay, we can overdiagnose, but we are over-treating these patients. We are over-treating them with unnecessary radioiodine. Okay, I agree about surgery, but not for radioiodine. Radioiodine now is not very safe. Now people are speaking about radioiodine causing secondary tumor. يعني يخلص من هنا يطلع له tumor في حتة تانية. This is now the Americans are going away from radioiodine. So please remember that you shouldn't be very aggressive. What about thyroid suppression therapy? You remember in cancer thyroid, usually we like the TSH to be low to avoid any remnant cells to grow. This is called suppression. And the guidelines say if it is low risk, you can keep the TSH between 0.1 to 0.5, not very low. because high risk, you give less than 0.1. So in this patient, either not to give suppression, because most of the data show it doesn't have a difference, or at least keep it between 0.1 and 0.5. Don't overdo it, because if you are going to overdo it, give a higher dose, higher rate of atrial fibrillation, higher rate of osteoporosis. So remember, suppression in this patient, use rather keep the TSH between 0.1 to 0.9. At the end, Madam Chair Lady, Mr. Chairman, and dear colleagues, the incidence of PTC now is growing because of the ultrasound and doing a lot of fine needle. The prognosis is quite good in this patient, unless in certain subcategories with a high score that I told you. In this patient, you have to be more aggressive. You have to do surgery, of course, followed by radio iodine, active surveillance, or non-surgical thyroid ablation by radio frequency is considered in some cases, but in Egypt right now, I think you can omit the last phrase. I think we will agree with me. And thank you very much for your attention.